Hello everyone, welcome back to my YouTube channel. In today's video, we're gonna discuss about polycystic ovarian syndrome, aka PCOS, aka Steen-Levy-Henthal syndrome. So before going to that, I'm gonna tell you about amenorrhea. Amenorrhea refers to lack of menstrual cycle, and we further divide it into two: primary amenorrhea, second amenorrhea. Primary amenorrhea stands for failure to initiate menstrual cycle at the time of puberty. Second amenorrhea, mainly cessation of menses for more than 3 months if the woman is on regular cycles, and more than 6 months if the cycles are irregular. PCOS is a common cause of amenorrhea or oligomenorrhea and is affecting around 15 to 20% of women in the world. PCOS is the common cause of endocrinological disorder of reproductive age, most common cause of hirsutism, and some clinical features are anevolution, hirsutism, oligomenorrhea, amenorrhea, obesity, while obesity also play a role in pathophysiology of PCOS, hyperandrogenism, insulin resistant, and you can also find multiple ovarian cysts on ultrasound. Acne is also a clinical feature. Genetics and obesity play a big role in pathophysiology of PCOS, and they both lead to insulin resistant. And insulin resistant, there will be a decreased uptake of glucose in the ovary, and then there will be less energy for follicles to grow, so the follicles cannot grow that much, and there will be so many follicular which have small size and they look like a cyst. So follicular cyst is just a misnomer. In PCOS they are small follicles. And insulin resistance also lead to hyperinsulinemia because the body is trying to compensate the glucose level in our body, and it's also lead to acanthosis nigricans. You can also find the acanthosis nigricans in obesity women and men on the skin foldings, and there is also increase in ratio of LH and FSH. There will be increase in LH which will lead to production of androgens in theca cells, and increase in androgens can convert into testosterone, and testosterone can lead to hirsutism and acne findings, and androgens can also be converted into estrogens with the help of aromatase, which is also present in adipose tissue. So obesity really play a big role in it, and increase in estrogen can lead to decrease FSH because of the negative feedback mechanism, because body already have so much estrogen, so it will give a negative feedback to our hypothalamus, which will release less GnRH. Less GnRH will decrease the production of FSH, and FSH lead to anovulation. We diagnose PCOS usually clinically by the Rotterdam criteria, in which we require 2 out of 3 things: oligomenorrhea, sign of hyperandrogenism like hirsutism or acne, or polycystic ovarians by ultrasound, in which you can see multiple follicular cysts or thick stroma. Thick stroma is the one responsible for hyperandrogenism, and ovary will be 2 to 5 times larger than the normal. And other lab parameters are increase in ratio of LH and FSH, especially 2:1 or 3:1. Serum testosterone will be increased, serum androstenedione, or we can also test for sex hormone binding globulin, which will be decreased in this case, and increase in serum insulin because of the compensation mechanism. PCOS differential diagnosis, you should always consider other causes of excess androgen production, and in these cases ovary will not be polycystic, so that will give you a huge hint in the question. And the causes include non-classic congenital adrenal hyperplasia, while classic congenital adrenal hyperplasia mainly occur in the infancy and which usually present with loss of salt wasting and hypotension, and in non-classical it can present after puberty. So to diagnose it, you should measure the 17 hydroxyprogesterone level, and that level will be super high, like greater than 200, which suggests you the diagnosis of non-classical congenital adrenal hyperplasia. And the other cause include androgen secreting tumors, which can be present in ovary or any adrenal tumors. And the testosterone level will be super high, like more than 150, while testosterone level is also high in PCOS but not high as 150 or more than 150. So that will give you a huge hint in the question. Treatment of PCOS, let's discuss the treatment in 3 different phases: anovulation treatment, irregular cycle treatment, hirsutism treatment. Anovulation treatment, the first line without any drug, is always weight loss, because weight loss help to ovulate women in 30% of cases, and the drug include metformin, is an insulin sensitizer which help around 30% women to ovulate, and the other drug is clomiphene citrate, which the women ovulate in 80% of cases and also get pregnant in 40% cases. The other drug include injection of recombinant FSH, GnRH, and the drug of choice is letrozole. So letrozole is an aromatase inhibitor. Aromatase is an enzyme which convert androgens to estrogen, and without estrogen there will be a positive feedback to our hypothalamus, and hypothalamus will produce more GnRH, and more GnRH which lead to secrete more FSH from anterior pituitary, and FSH will help to recruit more follicles. So letrozole is always the drug of choice of an evolution. Before it was clomiphene citrate, but nowadays it's letrozole. And the irregular cycle treatment include combined oral contraceptive pills. But if the woman also have migraine, so you should consider taking progesterone only pills. And the treatment of hirsutism include anti-androgens drugs like cyprotein acetate, finasteride, flutamide, and the first line is spironolactone. And you can also do some cosmetic treatment for the hirsutism. Nowadays, surgical treatment is also available, which include laparoscopical ovarian drilling. With the help of ovarian drilling, they take out the thick stroma of the ovary, the thick stroma which produce androgens, so there will be less androgens after the surgery. That's all for today's video. If you have any question, then you can contact me on my Instagram or Facebook. Thank you for watching.